Um, Good morning, everyone. Welcome to Naples and to the IFSO World Congress. My name is Abdurrahman Nimeri. I'm the Secretary Treasurer of IFSO, and I work in Boston, Massachusetts, in the U.S. And with me, I'll have him introduce himself, Professor Fabrizio from Federico II University. He was just telling me that their university was started in 1224. Next year, it will be 800 years since its inception. He's a professor of medicine and an obesity medicine specialist, so please.
Thank you very much. I am actually the one entitled to say to all of you, including you, welcome to Naples, being the local man. And I'm particularly glad to get the session started jointly with Professor Nimeri, and the topic is particularly hot, I would say. This is a hot topic because there have been discussion of the indications for surgery for class 1 and class 2 obesity, and the topic of today is on the new guidelines for developed by two societies, two associations, international associations. So I will be introducing the first speaker, which is Dr. Antonio Vitale. I hope he's yes, he's here. He will talk about...
Vitiello, Prof.
I apologize.
No offense taken.
Thank you. Dr. Antonio Vitiello, he will present. The title of the presentation is Systematic Review for the New ASMBS IFSO Guidelines.
Okay, thank you very much, Prof, and thank you very much, Dr. Nimeri. It's such an honor to be here to present our work in front of such an audience of experts. And I personally want to thank also Professor Angrisani, who is the president of this Congress, for the organization and the invitation. I just wanted to... Is this working? Yes. I just wanted to, remind you briefly the history of the indication for bariatric surgery. Everything started in 1985 when I was born, because the NIH, they did the first consensus conference in which they set the definition for clinically severe obese patients, and they said that you can, consider a patient clinically severely obese when the BMI is over 40. And in 1987, 2 years later, they also held another consensus conference, and they were discussing the outcomes of the jejunal bypass. And since that was a very malabsorptive procedure, they decided that probably that intervention needed to be abandoned. Fortunately, luckily, in 1991, a new consensus was held, and after 2 days of presentations and discussion, they, for the first time in history, they set the indication for bariatric surgery. They said, that you can perform bariatric surgery in patients with BMI over 40, or in patients with BMI in between 30 and 35 if there is a comorbidity. And for the first time, it was also said that these patients need to undergo a multidisciplinary evaluation. And this indication, they have been in place for 30 years, till last year when we were in Miami for the IFSO Congress, and this incredible, outstanding text was given us, and was also presented on stage and was published on October 2022 on SOARD and obesity surgery. And this paper, was written, as you can see, the list of authors. Among them, you can find the biggest experts, the biggest, global experts of bariatric surgery. They reviewed the literature, and they came up with major updates in the indication for bariatric surgery. Especially the biggest, the major update was about the threshold for the BMI. Indeed, now we can operate in patients with a BMI in between 30 and 35. We can also, the threshold is even lower if we are talking about the Asian population. even if that paper is an outstanding paper, is an incredible piece of science, we must be honest, and all the indications for bariatric surgery so far, they came from consensus paper or consensus conferences. And in the modern era of evidence-based medicine, the consensus, a consensus is still considered an opinion, even if an opinion in between experts. And if you want to write guidelines according to the modern methodology, you need to perform a systematic review of the literature. I'm sure you're aware that most surgical guidelines have been published in the last years following a precise methodology, and this precise methodology is the GREAT methodology, which allows you. Good morning, Professor Shikora. I want to say it's really an honor to presenting in front of Professor Shikora, and if you. The GRADE system is useful because you can, write a recommendation, and you can give this recommendation a score on the quality of the evidence and the strength of the recommendation. Of course, we didn't want to go there. We didn't want to rewrite. We did not have the arrogance to rewrite the indication for bariatric surgery, because the paper I showed you previously is an incredible paper. We believe in that paper, but we just wanted to help. We just wanted to give some support to these indications. So Professor Angrisani and Dr. De Luca, they were, some of the authors of the new indications, and they had a discussion with their colleagues from the IFSO and the other authors of the paper, and they decided to ask a group of Italian fellows to do some systematic reviews about each topic of the new indication, just to support them better. And regarding the indication for class 1 obesity, me and Dr. Chiappetta, we were in charge of this systematic review. So we did a search in 3 databases, ASMBS, PubMed, and Cochrane, of course. We searched for, you can see the string of terms: bariatric surgery or metabolic surgery or obesity surgery, and low BMI or class 1st BMI or BMI in between 30-35 or BMI under 35. We, of course, looked only for paper published after 2000, because we wanted to exclude all the cases performed with open surgery. We looked also for only the English papers and only for papers with sample size greater than 10. Of course, we followed the PRISMA guidelines, and you can see the PRISMA flowchart. At the end, we included 43 articles in our systematic review. We also divided, there is a presentation, I think, later about the Asian population, but of course we wanted to divide the articles in between those on Asian population and non-Asian population. We found 13 articles on Asian population, 7 retrospective, 6 prospective. They were published in between 2014 and 2022, so you can see these are very recent publications. This publication included more than 100 patients. 2 of these articles included patients with BMI under 30, and 4 papers also compared the results of bariatric surgery with medical intervention or a changing of the lifestyle. As you can see, the vast majority of these articles reported the outcomes of the Roux-en-Y or of the sleeve gastrectomy, but we found also article on ORGB and SADI. The median follow-up was good, was 30 months, and operative time, length of stay, and the weight loss, they were comparable to bariatric surgery in patients with BMI over 35. Very important, 0 mortality. Very important, clavy and dindo complication 3-4 acceptable rate in between 0 and 7%, and we found also a very good rate of remission from diabetes and hypertension. We found a larger number of articles published for the non-Asian population, 9 retrospective and 20 prospective, published in between 24 and 2022, including 23,000 of patients. 2 articles were on patients with BMI under 30. 4 papers compared the results of bariatric surgery to patients with low BMI, and 3 studies made a comparison with lifestyle intervention. And again, the main article, the vast majority of the articles reported the results of the Roux-en-Y gastric bypass and of the sleeve gastrectomy, but this is very important. We found also some articles in class first obesity reporting results of revisional surgery and of the biliopancreatic diversion. The articles on the biliopancreatic diversion, of course, were from Prof. Scopinaro. And this is very important because if you look at the complication Cleveland Indo 3-4, you can see that the range is very high, is very large, is going from 0 to 40%. But this high rate of complication, 40%, was reported after biliopancreatic diversion was almost abandoned everywhere. And for the other interventions, sleeve, Roux-en-Y, the rate of complication is acceptable. Operative time, length of stay, and weight loss was comparable to bariatric surgery in patients with BMI over 35. Again, zero mortality. Again, the remission from diabetes and hypertension was more than acceptable. Sorry. So, conclusion of our systematic review, the conclusions are fully supporting the major updates that were brought by the guidelines published last year, because bariatric surgery is safe and effective in patients with BMI in between 30 and 35 in Asian and non-Asian population. You have satisfactory remission of diabetes and hypertension, and so far surgery is still better than medical intervention. I want to be honest on this point, since we did the systematic review last year in 2022, in between 2022 and 2023. We know we have now new drugs, and maybe in the future we need to make future studies, prospective studies, comparing the new drugs with bariatric surgery in this class of obesity. And thank you very much for your attention. Thank you very much for inviting me. And I want also to apologize in advance. It's such an honor to be here in this session, but shortly now we are having our Italian Congress in the same time, and I have a commitment there. So after the presentation, I'm so sorry, but I have to go in another building. Thank you very much.
So for most of the presentations, we'll have the discussion at the end, but since Dr. Vitello, first, thank you for your work, and thank you for staying on time. Really appreciate it.
Thank you very much.
Maybe if there's questions for him, we can take it now, since he has to go to the Italian session. If there's any questions for him. I mean, maybe I'll have a quick question for you. So since the guidelines were published, there is adoption from insurance carriers in the US, both private insurance carriers as well as adoption from some self-insured institutions. And many surgeons now could actually...
We have another participant to the Congress.
many surgeons now could actually get patients through surgery using the new guidelines. Have there been any adoption of the guidelines in Italy?
Thank you for this question. I think that Maurizio De Luca tomorrow is having an entire lecture on this, and I had the privilege of discussing this topic with him. And it's tricky because now in Italy now in 2017, there was a law, and this law says that if you have national guidelines written by a national society, and these guidelines, they have been approved by the Ministry of Health, then if you follow the guidelines, you can do that everywhere, okay? So in private or public hospitals. Maurizio De Luca wrote the new national guidelines that have been presented yesterday in our National Congress. They are in the way to be accepted by the Ministry of Health. So we are getting there. But to be honest, we are working in a public hospital, so we can use these guidelines. We have started, using these guidelines. Who works in a private or some hospitals, they need to have the reimbursement from the Ministry of Health. And now, since the Italian guidelines, they've been not accepted yet. If they try to do this surgery in patients between 30 and 35, maybe they will not be reimbursed. So they are still waiting. So we have, we in the public hospital, currently we have an advantage.
Thank you. Thank you
You're
so
welcome.
much. So it's my pleasure and privilege to introduce next Dr. Asim Shabir from Singapore, who's going to speak to us about metabolic and bariatric surgery in class 1 obesity in Asian patients. And as I said, please save your questions to the end of the session. We'll have a discussion for all the speakers.
A very good morning. Thank you very much. Thank you for the honor of the podium, and thanks for the kind invitation. I'll be speaking about bariatric and metabolic surgery in class 1 obesity in the Asian population. I have no conflicts of interest to declare. So these are the guidelines that came up and published in 2022, and basically the key take-home messages for the Asian was that the BMI thresholds were lowered, and 25 BMI and above were actually considered as clinically obese and not just overweight in our population. When these guidelines came out, these are the prevailing indications in various countries of the societies that belong to IFSO, the different chapters, national bodies. So you can see that most of us are around 27.5 and 32, which is where the society, IFSO, and the guidelines would put Asia at. And these include vast part of the eastern part of Asia as well. This is the old consensus, so I'll be talking about the obese class 1 at this point in time. Surprisingly, as you move east from the west, the BMI starts reducing. You can see the Arab countries largely represented in the red there, and the Eastern Asian represented in the blue there. So there is a decrease in BMI. However, over the years, the prevalence of obesity and type 2 diabetes across the Asian subcontinent has been rising and is predicted to continue to rise. Before I go on to the next, I think I need to do a little bit of fact check about Asian. Why is it such that everybody's so worried about the Asians? And we do have a higher body fat percentage for given BMI. Our BMI cutoffs for metabolic risk are lower as compared to our Caucasian counterparts. And Asia has one of the largest younger type 2 diabetes population. And most of them are poorly controlled, and they are associated with early morbidity and mortality in our patients. And if we look at the pathophysiology, the only thing that we can intervene is to decrease insulin resistance, and perhaps one best way of doing that is actually to treat obesity. And when we treat that, we hope that whatever beta cells mass that we have in our patients would survive and will continue to keep our patients euglycemic. These are some of the early indications that came out long before you could see them on the world map. This was produced by Mufassal Lakdawala and the Asian Consensus team, published in Obesity Surgery in 2010. Even at that time, a BMI of 30 and above with 2 or more comorbidities was an indication for bariatric metabolic surgery in Asia. So we have long sung the same song for a lot of time. Then came along IDF in 2011, and they reduced the scores for Asian by 2.5 and bringing it down to 27.5 at that point in time. Then came along the DSS, and here again, class 1 obese are basically encouraged patients in Asia to go for bariatric metabolic surgery, especially if they are pregnant. Was there a difference between those who were standard practice 35 versus those below 35? This data from the forest plot from Diabetes Care from Professor Rubino, who is among the audience, clearly showed with few Asian patients from Saeed Ikramuddin and Liang there, showed that it was definitely beneficial and favored surgery over lifestyle. There have been many such publications that, as we heard earlier, have been on there, and one of the earliest was from Mufi publishing 5 years outcome quite some time back as well, and showed positive outcomes and safeties in these patients. This is a 5-year outcome of bariatric surgery in patients less than 35 BMI, 5 years outcome from a Chinese study. Not only does it show that it is completely acceptable to do surgeries, it is also safe. If you look at the mortality at 5 years, comparing surgical group versus medical therapy, mortality is also low in the surgical cohort. And do these patients really, because if insulin deficiency is going to be a key factor in determining how they remain euglycemic, you can see that far out in 5 years, they continue to remain well within the euglycemia range or the appropriate glycemic range that they have to prevent long-term complications. So this is a meta-analysis and a systematic review looking at 16 studies published in 2018, and it showed that bariatric surgery in Asians for 25 and below 35 were actually quite safe and well done. This is the long-term outcome of a trial, Roux-en-Y versus, I think, best sleeve gastrectomy for Chinese patients, where you see great outcomes at midterm, which is about 3 years into study. And you can see patients continue to remain euglycemic in this study. What about the newly added OAGB? This is a study coming from India from Professor Kuller himself. And you can see patients continue to lose weight. They do not, even though they are below the threshold of 35, they do not go to the other end and become malnourished and below the 20 BMI. So you can see they maintain at 24. Yet that little small loss in BMI, as you would see, actually gives quite a nice complete remission in these patients. About 53% at 7 years out, and the improvement in HbA1c still continues to remain staggering in these patients. So when we talk about the Chinese population here in this randomized trial, you can see that they have segregated patients based on their BMI class. So across all BMI classes, it seems that bariatric surgery continues to be effective in treatment of diabetes in these patients. When we look at the outcome in a systematic review for the Chinese type 2 diabetic patients, you can see that the HbA1c, which continues to remain at 6.5 and below, remission rates as time passes by, even up to 5 years, is quite high in this population. This is a systematic review of less than 30 BMI, just recently published by G et al. In obesity surgery. BMI at 1 year, they favor, so patients tend to lose more weight as compared to before surgery, and the HbA1cs at 2 years are well maintained with the normal range in this study. And this continues with the effect that we see that there is a rise in GLP in these patients out at 2 years as well. So there is something there beyond weight loss, and possibly what this suggests is possibly could this be related to the incretin effect, which we are all aware, though not the sole process of such outcomes. The duodenal exclusion theory, when it came in with Professor Cumming bringing it in, there's a lot of change, and a lot of Asian surgeons now are doing duodenal exclusion procedures. You can see a whole list of those sleeve plus procedures that are listed there. Among one of them, which has taken popularity and has been popularized by Kasama, who is probably among the audience here, is the sleeve DJB. And it has served this population well because of special needs within the Asian cohorts of diseases like gastric cancer. We have a high prevalence of gastric cancer. Surveying the bypass stomach is rather difficult for us, and so that's the need to do such. With that, I'd like to thank you for my presentation.
Very nice presentation. I'd like to ask you a question. Asia is a very big territory, and the people in Asia are quite diverse. You have Han Chinese, you have Pakistanis. People genetically are different. Did you find in your reading that the results of gastric bypass or bariatric surgery was the same for all Asians, or better for some than others?
Okay, so we did look at the ethnic differences in patients across Asia in one such study that we did, though it didn't apply to necessarily to low BMI patients. The outcomes in weight loss are different, but for the outcomes for diabetes, they are similar across ethnicities. So it's only that the cutoff values for where they start having diabetes for the Chinese is much earlier. It's at about 22.5. For the Indian Asians, it starts at about 23. And then for the Malays, it starts slightly later. But the outcomes are essentially the same after Roux-en-Y and sleeve till 5 years.
That's very interesting.
Yeah.
Okay, it's my pleasure to introduce the next speaker. He needs no introduction, but I'll do it anyway. Francisco Rubino, who's done a lot of work on diabetes and bariatric surgery, and he's going to present to us the class 1 patient with type 2 diabetes.
Good morning. Thank you, Scott. Thank you, the panel, and thanks, IFSO, for the invite. These are my disclosures. Of course, this is a topic that for me is very dear, is very important, and I was pleased to see that there is convergence now towards indicating surgery for type 2 diabetes in patients with BMI below the traditional threshold of 35. This is the IFSO ASMBS statement. And I want to focus this presentation on these 3 points of the statement that says, of course, surgery is recommended in patients with type 2 diabetes and BMI as low as 30 or below for a patient of Asian descent. And more importantly, that obesity definitions using BMI threshold do not apply similar to the all population, and perhaps access to metabolic surgery should not be denied solely based on traditional BMI risks categories. In 2000, actually a little bit earlier, it took a little while until we were able to publish this paper. We argued that there was enough evidence, even without any single randomized clinical trial, to use and consider surgery for type 2 diabetes beyond and below the traditional BMI. The reason for that we articulated in this paper was that there was no reason why BMI should predict response to surgery. There is no reason why, while BMI can be, in fact, a predictor of diabetes development, that BMI is not a matrix, it's not a measure of diabetes severity or even the type of diabetes. So if a surgical operation works on diabetes, it will not stop working magically at BMI 35. We also reviewed the literature before then. Of course, there were no randomized trials, as I said, but there were a lot of observations of surgery in patients with low BMI and diabetes, including from non-bariatric procedures like gastrectomies. And reports showed both efficacy in a way on the one hand and safety on the other, in the sense that no patients seemed to demonstrate excessive weight loss after this type of operation. So why not to use surgery? Of course, there was a little bit of a pushback by both the medical non-surgical audiences and by insurance, of course, because thresholds BMI were serving multiple purposes more than perhaps in patients' interests. In 2007, with the first diabetes surgery summit, we had a first international agreement that BMI 35 should not be a limitation for surgery, at least in patients with type 2 diabetes. And you can see that after the first DSS, we had at this point a number of randomized clinical trials being performed and published, and so the evidence building up much more strongly as you can see. And so this paper has been already discussed, and this is a meta-analysis of all the randomized clinical trials, so only randomized clinical trials that show that included patients with BMI above and below 35. In the aggregate, there was no evidence whatsoever that there is a cliff at BMI 35. So at least in terms of efficacy, there is no indication that there is a difference. And also, after that meta-analysis, a number of other studies have been published. Some of them have been presented just before. This was also from Ricardo Cohen and colleagues with 5 years follow-up. The primary endpoint here was renal, diabetic renal disease, however, control. And however, all these patients had diabetes, and all of them were BMI below 35. You can see glycemic control, as expected, is better with surgery compared to intensive best medical therapy. Again, also similar findings in other studies. This is the STAMPEDE trial by Folshowers and colleagues. They had a randomized trial comparing sleeve gastrectomy, gastric bypass, as you know, in medical therapy, and they looked at, they made a subgroup analysis where they had patients with BMI above and below 35. When you look at glycemic excursions across a number of years, there is no difference whatsoever. If patients have BMI 35 or below, they respond in the same way to both medical therapy and surgical therapy. So really no reasons to deny surgery in patients with BMI below. So other studies in the aggregate have shown that even in patients with class 1 obesity, diabetes goes into remission, and durably so. There is excellent glycemic control overall, and reduction of cardiovascular risk, medication usage, lower incidence of diabetes-related complications, including renal complications and others, greater weight loss, even in patients with lower weight, there is greater weight loss still, and better quality of life. So in other words, exactly all the benefits you normally expect from bariatric surgery, you can see those benefits happening in patients with BMI and with class 1 obesity. So perhaps not surprisingly, now at least the medical profession is formally endorsing use of surgery in BMI below 35, in class 1 obesity, for type 2 diabetes. These were the last DSS guidelines in 2015, endorsed by 56 organizations from around the world, including IFSO, of course, but also including the American Diabetes Association and all other major diabetes organizations. So basically now, we have worldwide a number of statements and guidelines and clinical guidelines from multiple organizations that do recommend using surgery in class 1 obesity if patients have type 2 diabetes, including, as it was said before by our chairman, national healthcare systems or even private insurance now covering the use of surgery in many countries already. So hopefully I'm glad to hear that Italy is catching up on this as well. Now, based on all this evidence, the journal like The Lancet a couple of years ago put on their front page, not on the back page, on the front page, that metabolic surgery is more effective than conventional medical therapy in the long-term control of type 2 diabetes, period. It didn't say BMI above 35. It just said it's more effective, period. So there is finally more support, endorsement, broadly speaking, for surgery as a standard therapy of diabetes, multiple organizations, not just surgeons and surgical organizations. So that's all good. But are we really making actual progress? We got the guidelines, we got the evidence, but where are we? So I invite you to come tomorrow to a symposium at lunchtime where the Metabolic Health Institute is a non-profit organization recently founded that aims to bridge professional societies and the public and various professional societies together, investigating what public opinions and public education is around various treatments for obesity and diabetes, not just surgeries. It's across the board. So we ran through this organization a survey among 1,000 US adults with obesity and asked a number of questions. Now, the more hot questions, I'm not going to disclose it today. You're going to have to come tomorrow to the symposium because they're going to be very important questions about how drugs, if drugs do convince patients not to have surgery, or maybe they might make patients consider surgery more. We don't know the answer yet until tomorrow. We'll let you know. But there was an important other finding in this study. When we ask patients what is the most effective treatment today for type 2 diabetes, you can see that surgery was not known by the vast majority of people to be even an option. So not surprisingly, we're not operating on patients. They don't know. They really don't know. And strangely enough, most patients think that they could do with diabetes or obesity just by dieting and exercising more. And that's the reality of what we're facing. This is true for severe obesity, and it's true for type 2 diabetes. And we also looked at whether patients had diabetes or not, and it doesn't really make a difference. Even patients with diabetes, you would suspect that people with diabetes will look into what are the options for them. It seems that we are not communicating efficiently enough. I want to conclude by saying that perhaps the very question at the base of this presentation is hopefully will become obsolete. Is it really possible still to question if we have to operate based on categories of BMI in 2023? Now, we know the prognostic factors of diabetes are many, and none of them looks like BMI. So why should we have BMI categories? The same goes for obesity. Obesity, once you have it, it's not the BMI threshold that tells you whether you're going to die, etc. So there should be other criteria to prioritize surgery, and the DSS has published some of these criteria during the COVID pandemic. But I want to conclude by saying that but you talk about bariatric surgery historically, you talk about an intervention to prevent something from happening. When we're starting to talk about metabolic surgery, we want to operate on people who already have developed disease, metabolic disease more broadly, or type 2 diabetes in particular. That changes everything. And because of that change in concept, BMI should not be a factor whatsoever. Finally, to conclude, I want to say that because of the very fact that BMI is not a factor, there is now a Lancet Commission at work which will produce a recommendation probably at the beginning of 2024 where we will define clinical obesity. So including for patients with type 2 diabetes, and there is, I cannot tell you the details of it, but I can anticipate that BMI thresholds will not be a reason to differentiate or discriminate between patients with clinical obesity, let alone, of course, with type 2 diabetes. So finally, hopefully next year at IFSO, we won't have to have this conversation anymore. Thank you.
Thank you. Thank you very much, Dr. Rubino. We will have the discussion at the end of the session. Thank you very much. Next speaker is Dr. Khaled Jodat from Egypt. My co-chair recommended me to mention that he is the chairman of the chapter, the MENA chapter, and he will talk about the class 2 obesity without obesity complications and what is the evidence. Please.
Thank you. Thank you very much. When Scott Shikora told me to make this presentation about type 2, class 2 obesity evidence, I thought, well, that's a piece of cake, no problem. So, but when I went through the data and started to prepare the presentation, it was tricky. So these are the classes of obesity. We all know the overweight, class 1, class 2, and class 3. And in 1991, the NIH proposed that BMI above 40 without comorbidity or 35 with comorbidity, which should be the threshold for bariatric surgery. And for the next 31 years, we tried to change this with the new guidelines. Now we have a BMI of 35 without comorbidity or 30 with comorbidity, but what is the evidence we have? So in 31 years, what happened? Why did we change? Procedures became safer. We had less morbidity, less mortality, and we also the shift from open to laparoscopic surgery. If you see, NIH was 1991, the laparoscopic era started in 1993, and that made a great difference. Better anesthesia, perioperative care, less hospital stay, early ambulation, surgical techniques, refinement, and we now have a completely different field from what we used to practice in 1991. That's an interesting study that showed the changes in utilization of bariatric surgery in the United States from 1993, 2 years after the NIH, until 2016, and it proved beyond doubt that everything is better, but we still have underutilization of bariatric surgery for our patients. In 1999 was this first international meeting I attended was in Naples, in Italy, and at that time we were talking about whether you should do a BMI 30 to 40 or not, because it was out of the NIH criteria. So whether you do it or not, or if you do it, what to do. And this was a discussion between me, Luigi Angisani, and Malfobi. And Malfobi at that time said, well, if he's an adult, consenting, fully informed, complications, and all the issues are informed, you do the procedure. Luigi at that time said, well, I would do the least. She's not that fat, so I'll give her the smallest operation, the least. I'll do a lap band. I told him then, well, it's a terrible operation. Why would you do a lap band on a patient? It's just, it doesn't work. But even VBG is better. Malfobi said, this is complete nonsense. So if you decide whether you do the exception or not, you're going to do the surgery? Yes, do the exception, but then do the best procedure. So if a patient at BMI of 35 wants an operation, I'll give her a banded bypass. And I stumbled upon this study by the Luigi Angisani and friends where he still did the lap band on this patient group, so Luigi. Yeah. You know, the deepest sin against human mind is to believe things without evidence. But also, if the truth shall kill them, let them die. So I tried first to find the topic of BMI 35 to 40, no comorbidities for bariatric surgery. And I started with the references that we had in the guidelines. But all the references we had in the guidelines were with comorbidities. So we were quoting the results of the no comorbidity group for the patients with diabetes, hypertension, etc. It makes sense because it works for weight loss on both, but at the end of the day, it's not the group without comorbidities. We also had statements from ASMBS in 2012 and 2018 and from the IFSO at 2014 because all the discussion with the NIH about changing their criteria has failed. So it was just statements from the societies that ended with the ultimate success of the new guidelines that we had. So this was in 2012. And this one was the IFSO one in 2014. And then we had the 2018 document too. So I tried to look into meta-analysis and bariatric surgery, and this is one of the most famous bariatric surgery papers. This was studied by Henry Buckwold, was cited 8,870 something numbers, and everybody looked at this, and it proved beyond doubt that we have a definite advantage for doing bariatric surgery in different BMI spectrum. Different meta-analysis, they all conclude that it works, but the distinction of 35 to 40 without comorbidity is not there. This is a nice meta-analysis from Australia by Paul O'Brien. He made a joint meta-analysis. He studied many pieces of literature combined with his own results on the lab band, and he concluded that they are all good procedures. All procedures associated with good weight loss and more long-term data is needed at that time when he published this 2019 for one anastomosis and sleeve gastrectomy. Another study, but still it's adding comorbidities, good results, outcome, comorbidities. Another meta-analysis, same good results. This is a study that compared different procedures, and it concluded that sleeve gastrectomy and Roux-en-Y is better than lab band for achieving sustained weight loss. And this is another point in our discussion, because we quote bariatric surgery as was one entity, and you know we have good procedures and bad procedures. So beyond doubt nowadays is that lab band is not as effective as other procedures. So we should stratify them into procedures. Procedure results too, because we see also a lot of papers talking about weight regain and weight recidivism and even initial weight loss failure. So it doesn't, it's not like a general thing that operations are good. And you know, all bariatric surgeons love before and after pictures. This is a nice before and after pictures because here the patient did not lose weight, they just lost time. So if you have a patient with an operation that will fail 5 years later, that's going to be the before and after picture. So for specific class 2 without comorbidity, these are lacking. We have scarce publications for that. So, but that will change. You know, this was not in the guidelines. So even if bariatric surgeons practice this, they would not publish their data. And now I think we're going to have plethora of data about this. I met Alfred Kosheri in London, and he says that there are patients whom we cannot help, but there are none whom we cannot harm. So in conclusion, metabolic and bariatric surgery in class 2 obesity without comorbidity is the most effective treatment strategy in this group of patients, but better procedure choice and better follow-up can give better long-term outcomes for these patients, and we need better randomized controlled studies, long-term follow-up data for that. I'd like to invite you all to attend our conference in Egypt, in Cairo, in next October, a very nice interactive bariatric conference. Thank you very much.
Thank you for a great presentation. We're working on that classification now with this second paper about the guidelines, which is underway. I'd like to invite the next speaker, Dr. Wendy Brown from Down Under, who's going to speak about the case of expanding the guidelines for metabolic bariatric surgery for high-risk patients such as the elderly, transplant, and cardiac.
Thank you very much, and thank you for the opportunity to present in this very interesting session. So, sorry, I think I've skipped through that. They're my disclosures. So we all know the indications for bariatric surgery have changed since 1991, and they've been updated in 2002. And the updated version in 2002 really states that we can start to consider this treatment for people regardless of their BMI, though we still have a BMI threshold in these of 35. And a few special populations are mentioned, but if you go through the guidelines, there's no upper limit for patients, but you do need to assess frailty and comorbidities. And it's also stated that it's an effective treatment for people with obesity who require organ transplantation. But what is the evidence for that? When we think about evidence, I don't need to tell this audience, we think about the levels of evidence, with the highest levels being systematic reviews of good randomised controlled trials and the lowest being consensus opinion. Then we use those levels of evidence to come up with a grade of opinion. And ultimately, particularly in these high-risk populations, what we need to be thinking about is what's the evidence for risk of harm versus what's the possibility of benefit. So if we think first of all about older people, the problem is that all the evidence we have is based on people with mean BMIs in the mid-40s, because the reality is we only have one RCT, and that RCT was based on people with a BMI of 46, and the rest of the information we have comes from large case series and cohort studies, again, where people have followed the guidelines from 1991. So there's very little evidence for people over the age of 65 in that class 1 and 2 obese group. Most of the evidence comes from class 3 obesity. So what do we know about class 3 obesity? We know that it is effective. There's 3 systematic reviews that show that there's comparable weight loss and resolution of type 2 diabetes in this population, and similar or maybe slightly higher complication rates. There's comparable outcomes with sleeve gastrectomy and Roux-en-Y gastric bypass, and the papers that have looked at LAGB have found that they've been maybe slightly less effective in terms of weight loss, in real terms maybe 5 to 10 kilos difference, but there was less complications, but in the longer term perhaps more. Cost effectiveness has been looked at in one paper, and again in this older age group it was found to be cost effective. So if we think that in a heavier weight, in the higher classifications of obesity, that it is like MBS is likely to be an effective treatment, then maybe we should be thinking about extrapolating that down to lower BMI groups, which potentially have a lower operative risk. And that's why in these recommendations we would say probably there's level 2A evidence, and a recommendation would probably be a B. However, I think in the older population it's really important to think about what we're trying to achieve. In people over the age of 65, they've often already got end organ damage from their disease of obesity. And we look at the years of life's gain as people get older, going up the age groups. The darker bars are people 60 and 70. When the BMI is 30, people are likely to lose 2 years of life if they lose weight. And if their BMI is greater than 45, it's possible that they'll even lose weight there. There's something called an obesity paradox that nobody's really been able to explain totally in older populations, that in some ways being heavier can be protective when you're older. We also have to consider frailty, because not every person over the age of 65 is the same. And there's a very nice Canadian study of Agey Healthing Frailty Index, which has been applied to bariatric surgery frailty. And I think if we are thinking of operating on someone in those older age groups, we need to take the individual into consideration and think, what is the risk for that person? What is the number of life years gained? And what is the possibility of operative risk? Because as Francesco said, we're not really operating for weight loss, we're operating for health improvement. This is health-giving surgery, not weight loss surgery, particularly in this age range. So without evidence at the moment, I think what we really need to do is look at the individual and come up with what is a reasonable option for those people, because probably the comorbidities you're going to help the most in people over the age of 65 is their joints. How about another high-risk group, which is solid organ transplantation? This is a talk in itself, but this is a 10-minute talk covering a few different things, so I've tried to summarise it in one slide. Again, we're stuck with case series and cohort studies with only one systematic review looking at outcomes of cardiac transplantation. And again, all of these studies have focused on people that fulfilled the previous NIH criteria, which is a BMI greater than 35 or 40, and all of them have people in those higher groups. It's interesting in this area because we're not just thinking about whether or not weight loss will help people with their disease that's leading to have them to need an organ transplantation, and there is good evidence that sometimes, particularly in cardiac transplantation, if people lose weight prior to cardiac transplantation, they may not need cardiac transplantation because of heart failure improvement, or it may defer the need for it to down the track. We're also thinking about whether or not they can qualify for a heart transplantation because or a solid organ transplantation, because most transplant programs require people to be in a normal weight range, which realistically we don't always achieve with bariatric surgery, metabolic bariatric surgery anyway. And we also need to be thinking about what the risk is of the drugs that people who have solid organ transplantation need to maintain their transplant. So what the risks of immunosuppression mean to the short-term and long-term complications of our procedures. So it's a very complex area, and most of the study would suggest that obesity, weight loss achieved with metabolic bariatric surgery can increase transplantation rates and may defer the need for transplantation. Most of the studies will say that solid organ transplant can be safely performed after metabolic bariatric surgery, albeit with a slightly higher risk profile. And of the available operations, it's suggested that maybe sleeve gastrectomy may be preferred due to the fact that it's safe. And there is now an emerging evidence, particularly with liver transplantation, of concurrent performance of these procedures. So the summary of this is that we do have some level 2 and 3B evidence, and probably recommendation B, but we don't have as yet any bespoke evidence for that class 1 and 2 obesity. And it may be that this is a group where the medications may be better for our patients, but again, I think it comes down to personalised medicine and having an individual dialogue with that very high-risk patient. How about heart failure as a disease? There is one very good systematic review that's shown that bariatric surgery effectively targets cardiovascular risk factors, and that metabolic bariatric surgery can be a really important tool in improving cardiac failure. And in this meta-analysis that looked at all-cause mortality, heart failure, atrial fibrillation, myocardial infarction and stroke, surgery was seen to be better than control group that had best medical management. But again, all of these trials have been performed according to the previous NIH standards, and we don't have bespoke evidence for that class 1 and 2. So an all recommendation for heart failure would probably be a 3A with a recommendation B. But again, in a high-risk group, it's going to come down to personalised medicine principles and that real conversation between a clinician and their patient about what the risk-benefit is. So whilst I think there is some evidence that there is benefit for metabolic bariatric surgery in class 1, 2 and obesity with high risk, such as older age, solid organ transplantation and heart failure, at the moment, the evidence really only supports in class 3 obesity. So therefore, it comes down to personalised medicine, knowing your patient, discussing with your patient what's the risk of the harm and what's the risk of the benefit. So at the moment, I think we'd have to say in this space, we have a real need for randomised controlled trials and high level evidence. But I'd have to say I think that might be almost impossible to do in these groups, because equipoise will mean that it may be unethical to even do some of these trials. So there may be a role for registries in national societies, running registries, capturing these data at a high level, and maybe even performing cluster randomised controlled trials where we can try to gather higher level evidence together to come up with some solutions. I think that the real key in this situation is considering the risk-benefit comparison And in doing that, you need to consider frailty scores, particularly the bespoke bariatric surgery frailty scores. When you think about risk calculators, we need to think about the likelihood of achieving not just weight loss, but health benefit. We need to think about cost efficacy, what's the safest option, and ultimately where you do the surgery, where you do it, that can consider the special needs of those patients. So it's been a very quick overview of a complex topic, and I thank you for the opportunity. I've learned a lot in doing this talk. I hope to encourage you all to come down to my hometown, Melbourne, next year, where we're going to integrate your future patients teams in Science and World at our Congress. It's a beautiful city. This is the view from my balcony every morning when the sun's coming up, and when I go for a run and along our beautiful Yarra River, and I hope I get to share that with you next year in Melbourne. Thank you very much.
Thank you, Professor Brown, for an excellent talk and for staying on time. I want to thank all the speakers for doing that, and that will allow us to have an excellent discussion. So next, it's my pleasure and privilege to introduce someone who needs no introduction, Professor Lillian Cao, who's the past president of IFSO and the vice chair of the IFSO Board of Trustees. She's going to talk to us about metabolic and bariatric surgery options in a patient with class 1 or 2 obesity and a large abdominal wall hernia.
Thank you very much, Dr. Nimari. It's my pleasure to be here today with you. And my brief today is to talk to you about our recent guidelines and the options about repairing a large abdominal wall hernia. This is my case mix disclosure. You know, I come from Australia. I started my career with gastric bands and moved on to sleeves and gastric bypasses. I have no potential conflict of interest to report on particular with this session. So when the 2022 ASMBS IFSO indications for metabolic and bariatric surgery came out, they stated that in patients with severe obesity and abdominal wall hernia requiring elective repair, metabolic and bariatric surgery should be considered first to induce significant weight loss and consequently reduce the rate of complications associated with hernia repair and increase durability of the repair. So what is the evidence from this statement? We had a team run by Maurizio De Lucia to look at the evidence, and this is how he went through his analysis. He did a prisma looking at metabolic bariatric surgery and abdominal wall hernia repair. He used a prisma analysis, and he went through and found 2,241 records, of which 37 were full-text articles, and finally 23 were suitable for inclusion in the analysis. So based on this, he could do a systematic review, but not a meta-analysis, on 5 national registries with numbers over 28,000 and 18 single retrospective studies totaling over 1,000 patients. So overview of the studies, what did he find? He said heterogeneous way of dealing with the abdominal ventral hernias in terms of timing, technique, the types of hernia, and even the type of surgery. So with regards to timing, there were some that had their repairs before their bariatric surgery, some had it with their bariatric surgery, and some after stage weight loss. And the ones that had their surgery before their bariatric surgery, they were mainly ones that were symptomatic or presented with intestinal obstruction. In terms of technique, they were open and laparoscopic, plus or minus meshes. Of the ventral hernias, there were primaries and recurrence, and there were various types of hernias, including epigastric, umbilical, paraumbilical, and spigelian. And of course, coming to metabolic and bariatric surgery, it was a range of options as well. This is one of the studies who looked at the abdominal hernia and whether they repaired these patients before or after surgery, and they came up with 3 options. For the small hernial defect, which is defined by less than 4 centimeters, even if they were symptomatic, they felt that they should be repaired first before they had a subsequent bariatric surgery. For those that were asymptomatic, they still did their surgery, but also for some of them, they had a concomitant or probably subsequent bariatric surgery. But for the larger hernias, more than 4 centimeters up to more than 10 centimeters. They felt that those that were symptomatic should have their hernia repaired first, and those that were asymptomatic to have their bariatric surgery and come back for the hernia repair. So there were studies that looked at the timing of their ventral hernia repairs, and there were several options. Some recommended that they have their bariatric surgery with or without their ventral hernia repair. Some recommended that they have ventral hernia repaired first and then have their bariatric surgery, and so on and so forth. So there were many options that they had to analyze. Well, first of all, they looked at what are the outcomes. Excuse me. If you look at length of stay, it was heterogeneous. Some reported a decreased length of stay if you had their ventral hernia before their bariatric surgery. Some reported decreased length of stay if you had their ventral hernia repaired after their metabolic and bariatric surgery. And there were some that also recorded decreased length of stay when they had concomitant hernia repair with their bariatric surgery. What about outcomes in terms of morbidity? They looked at hematoma, seroma, and surgical site infections. When they had their ventral hernia deferred, it was about 37% of those patients came back with small bowel obstruction. Of those that had concomitant ventral hernia repair with their bariatric surgery, 4.6% had a surgical site infection. When they analyzed whether they had concomitant surgery or just bariatric surgery alone, there was increased incidence of surgery if they had the double surgery. For example, there was a reoperation rate that was increased from 2.3% versus 1%, and this was statistically significant. There was an increased return to the operating theater within 30 days, 3.3 versus 0.6, and there was also an increase in the readmission rate, 3.2 versus 5.9. In terms of seroma, those that had their operations before their surgery, there was increase while they were obese, but less so after their bariatric surgery. Similarly, with infections, there was increased sepsis and surgical site infections for those that had concomitant repair compared to a single operation. There were 5 national registries that were analyzed in this overview. In terms of mortality, it was not significant whether they had 1 operation or 2 operations together. But what they did come back and concluded was those that had their metabolic and bariatric surgery together with their ventral hernia repair, there was increased morbidity such as infections, complications, 30-day morbidity, and increased recurrence. So at the end of this, the recommendation is that obesity is a risk factor for the development of ventral hernia, and the evidence suggests that patients with abdominal wall hernia may benefit from significant weight loss before their hernia repair, and in patients with severe obesity and abdominal wall hernia, bariatric surgery-induced weight loss should be recommended before their ventral hernia repair in order to reduce the rate of post-operative complications. So the level of evidence here is 2B, grade of recommendation is B, and it's about right in the middle of the level of evidence. Thank you very much. And again, like Wendy, I'd like to invite you, not to my hometown, but to Melbourne in Australia, where we'll give you a wonderful time with our World Congress next year. Thank you.
Thank you very much, Dr. Kau, for your contribution. And the next speaker will be Dr. Rosenthal. Dr. Rosenthal, it's my pleasure to introduce him. He's the editor-in-chief of the journal Sword, and he works in Cleveland in the United States. Please, Dr. Rosenthal.
Thank you.
Yeah.
Good morning, everyone. It's a problem that you cannot hear when you're on the back. So if you can put my first slide on. Thank you very much. So this is a topic that has really captivated me about 5 to 6 years ago, and I want to share with you why. The first thing that happened was when Ted Adams published this in New England Journal of Medicine, he looked at a group of 7,900 obese subjects that had bariatric surgery that went to get their driver's license in the state of Utah, and took 7,900 that had a gastric bypass. And then he said, okay, let's see how these guys did. And this was published in the New England Journal of Medicine, and he looked at mortality. So the first take-home message is that mortality was decreased by 40%. But if you look at this, 60% of those that died from cancer. So one of my residents at that time and research fellows, Camila Ortiz, kept doing some research on this. And then we stumbled across this publication by Dr. Daniel Schauer, not the Phil Schauer we all know from the Stampede. This is Daniel Schauer from Kaiser Permanente. And Kaiser Permanente is a big healthcare organization in America. They capture hundreds of thousands, if not of millions of lives on a yearly basis on the West Coast. And he did a multi-site cohort study, 5 study sites, 10 years, a very, very well-matched cohort between those who had bariatric surgery and those who did not. Look at the number of non-surgical cases he was looking that were obese, 16 million, compared to 33,000 surgical cases. So, as I told you, they were very well matched. Take a message, why is this important? Because if you're obese, the likelihood of developing cancer is increased by 50%. But if you're obese and diabetic, it's increased by 200%. We don't know why. We're going to learn about that this afternoon if you can. But what you can see here from his study is that those who had bariatric surgery had a much larger cancer-free survival than those who did not have bariatric surgery here. So this was a take-home message, that if you do bariatric surgery and lose weight, the likelihood of you developing cancer is much lower. He then looked at the same cohort, very well matched, 5 study sites, 10-year follow-up, 40,000 versus 18,000 surgical cases, 1 year and 10-year follow-up. And what he taught us here, that if it is not a matter of how much you lose, the more you lose, the higher is going to be the likelihood that you're going to have a cancer-free survival. So this is another take-home message, because it is not just about getting on a diet and losing 10 pounds, and I'm going to have a protective effect against cancer. I need to lose at least 30% of my excess body weight loss, something that they couldn't achieve. So there are a lot of publications, and we are running late. Thank you for the speakers that were before me that took away my time. But this is something also very interesting. This is from the LAPS study that shows exactly what Dr. Schauer just showed us, that it doesn't matter, or it's not only how much you lose that really matters for you to have a preventive effect. This is coming from British Journal of Surgery, looking at hormone-related cancers, and what they found here in a prospective randomized controlled study, that bariatric surgery in blue, has a protective effect against developing hormone-related cancer versus non-bariatric surgery in red. So as time passes, those who did not have bariatric surgery started having cancer and died from that. And gastric bypass, obviously, regardless if it's a bypass, a band, or a sleeve, if you lose what you need to lose is what really matters. The American Society of Metabolic and Bariatric Surgery published also guidelines stating clearly the beneficial effects of bariatric surgery. This is a great paper from Nazario. Why? Because what Nazario is showing us in this paper is that the incidence of breast, ovarian, and uterine cancer, and I'm not going to go into the numbers because it doesn't really matter. It's so highly significant. You're going to learn this afternoon, if you come to the course, that the CDC in the United States of America published in 2017 that if you are a postmenopausal obese woman, the likelihood of you developing cancer is increased by 55 to 60%. So the numbers are staggering. Doesn't matter where you look at. We presented at ASMBS a retrospective review from the NIS database, which probably for those who are in the United States know, which is the largest all-payer inpatient care collection, hospital care data, comparing the control group, surgery, in the case group, 250,000 versus the control group, no surgery, 1.4 million patients. And what we could see that the odds ratio of developing cancer was much higher in the control group without surgery than in the case group with surgery. And that was even significant for those who had a family history of cancer or were smokers. So I'm not suggesting that you should smoke and have bariatric surgery and everything is going to be fine. But I'm going to tell you that even if you smoke, and even if you have a strong family history, bariatric surgery seems to have a good effect. We looked at liver and presented this at the American College of Surgeons, that there is a higher risk of developing liver cancer if you are obese. And we separated diabetics and NASH versus NASH alone. And what really matters is the NASH more than the diabetes, although the diabetes matters as well. We looked the same thing at colon cancer and presented at the American College of Surgeons at the Surgical Forum. And the family history of colorectal cancer, polyps, are stronger. But if you have a polyp and you're obese, the likelihood of you developing colon cancer is much higher. And bariatric surgery, looking at NIS database, seems to have a positive effect in preventing that from happening. And last but not least, Mr. Chairman, to save some time for discussion, this is the SPLENDID trial. And this in America made headlines in the New York Times. And I have to give credit to Dr. Amini, and he's going to present it himself this afternoon if you have time to come and listen to him. The SPLENDID trial looked at the Cleveland Clinic 10 years data of patients that were obese and had bariatric surgery versus patients that were obese and did not have bariatric surgery. And what we looked at was at the incidence and mortality because of cancer. And we matched them 1 to 5. 1 bariatric cases, 5 non-bariatric cases. And that is how we ended up with nearly 5,000 bariatric cases compared to 25,000 non-bariatric cases, 10-year follow-up. Let's see how they do when it comes to incidence of cancer and mortality. And what you can see here, and I highlighted that in red, that the likelihood of developing cancer was significantly higher in the non-bariatric group by 4.9% versus the bariatric group, 2.9%. And the mortality was also higher because of cancer in the obese group that did not have bariatric surgery down here. This mouse is not working. About, I would say, again, 0.8% versus 1.4%. To be a little bit more granular, what you can see here in these numbers is that those who had bariatric surgery lost much weight in orange than those who did not have bariatric surgery in blue. And what you can see here is that depending on your BMI, the higher was the likelihood of you developing cancer. So those who did not have bariatric surgery and had the highest BMI were the ones who had the highest incidence of obesity-related cancers. And these graphs here, what they're showing us are those who did not have bariatric surgery in blue versus those who had bariatric surgery in orange had a much lower incidence of cancer. Here you can see the bypass and the sleeve. They are equally protective when it comes to no developing cancer. You see those who did not have bariatric surgery up here had a much higher incidence of cancer. Those who had bypass or sleeve, they had equal protective effect against obesity-related cancer. And when you can see here, the mortality rate for those who did not have bariatric surgery was much higher than those who had bariatric surgery. So in summary, our conclusions was that bariatric surgery seems to have a protective effect, not only in decreasing the incidence, but also the mortality of obesity related to cancer. And I think as a conclusion that it's probably time to update our guidelines, Dr. Shikora. Thank you.
Thank you very much. As always, wonderful presentation and getting the message out. We'd like to bring up all the speakers now for a panel discussion.
everyone. My name is Hazim, consultant surgeon from Abu Dhabi, United Arab Emirates. Thank you all very much. I would like first to thank all our speakers for such a comprehensive review for an important document. Been asked to run the discussion. Has anyone got any question? And if not, I would like to address our speakers if that's possible. For those of you familiar with the document is quite comprehensive. It covers lots of aspects of individuals suffering with obesity, the evidence behind the recommendation, but there's a group that was not discussed today, and I think it's because of a time constraint, which is a future bomb coming to us later on in our life, which is obesity in adolescents and children. And if I don't mind, I would like to ask our speakers to share their thoughts about such a topic, which is quite close to me, because where I practice, we work in a children's hospital, we do a lot of surgeries, and we could see that the metabolic impact of obesity on children is probably more pronounced on that on adults. And it's probably related to the diet that they follow. So if anyone has got any thoughts, I believe Dr. Khalid, you've got a big experience in my part of the world in surgery for adolescents and children.
Yeah, we started actually in the 90s doing children and adolescents, but we had more stricter criteria because we were against the NIH laws, so we were doing BMIs above 50, and we did all types of procedures for them. And now with the regulations, I think it's becoming commonplace to do adolescents. And in India now they do 2-year-olds, but that's too much. But I think it's the way forward, but we still need evidence for that.
Any other thoughts?
There is a session on this I think at 12:30 in this room. I think I'm speaking in it, but just I think there is evidence for adolescents in particular. The evidence is that all procedures are reasonable, but probably things like sleeve gastrectomy are a little safer, and also gives options for the future if we consider obesity as a lifelong disease. The paradigm might change because of the medications, but tanner stage and puberty stage probably aren't as important as we thought. There's really not much in the way of evidence for children, for non-adolescents.
Thank you.
So maybe I have a quick question to Professor Rubino. So what could we learn from the diabetes surgery guidelines that were done in 2015 in regards to adoption that we could do for the current guidelines to make sure that they don't, at least in the US in 2004, there was a big effort to publish new guidelines. 2 societies, didn't go anywhere.
I think in 2019 in New York, we had an additional meeting where we just tried to address the issue of implementation of guidelines, because it's important to have guidelines, but if nobody uses, what for? The problem remains, in my opinion, that number one, there is a bias. Weight bias is pervasive and affects everything, including insurance coverage, as you know. But what we are realizing with some of the surveys that I just mentioned is that the public does not know how effective bariatric surgery is for severe obesity. They don't know about cancer. They don't know about diabetes. So I think we have to stop talking to ourselves, and we have to start talking to the public. And that's probably the most important message I think we have to convey.
Any questions from the audience? Can you introduce yourself?
Hello, thank you. I'm Ali Vahidrat from Iran, bariatric surgeon. I want to ask Dr. Rubino that what are the evidence of bariatric surgery on obesity class 1 patients that have type 2 diabetes mellitus? We know that bariatric surgery are effective on type 2 diabetes mellitus with patients with obesity class 3. And what are the effect of bariatric surgery in class 1 obesity or overweight patients? Are these as effective as they are in obesity class 3 patients? Thank you.
If I have to summarize in just one line, there is no evidence, to my knowledge, that there is any difference in efficacy between, for diabetes control at least. If you do surgery in class 3 or class 1 or class 2, it just doesn't have any difference. The difference depends on whether or not patients have longer diabetes status or less insulin reserve, but that applies to any class of obesities. If you have somebody with long diabetes duration in class 3, it will be less responsive to surgery in the same way as people in class 1. So as diabetes, everything being equal, BMI doesn't make a difference.
I have a question, Dr. Asim. You talked about a quite important point which pharmacotherapy is starting to teach us, which is that there should not be a BMI threshold when considering bariatric surgery. For you, what consideration would you take if you are to consider operating, for example, outside the guidelines, say for a BMI of someone with a 27 or 28 of an un-Asian descent? And what are the criteria that you would take into consideration?
Okay. So, not that I spoke about it, but yes, I can answer that question. I think BMI, as I presented in the work that we've come out from Asia, basically, and even in non-Asians it holds true, is that BMI is just a surrogate of a disease that you're looking at, and you're just trying to put the eggs in one basket to sell them in a tray that you have tried and made, right? You're just customizing that tray and trying to put every egg into it and say, I'm giving you 12 a dozen eggs here. But that's not the true fact of it. The fact of it is that what we're trying to do is we're trying to decrease insulin resistance, and as long as that exists, there is a room to improve the diabetic care of this patient. That can go down to different races, and it's just for insurance payers and all that we work these mathematics out. But as long as you believe that there is something you can do to help, and it can help the patient overcome the troubles that the patient goes through, one, and it is safe, and it is effective, and the patient will carry on with this, I think it's reasonable. In the Asian context, you will see a lot of people operating at 27.5 and above, despite being out of the guidelines, because we do not have insurers who pay for it. Patients pay out of pocket, and they're willing to pay for it, and they do get the outcome. So whether BMI becomes relevant or irrelevant would be something that the insurers will decide.
Thank you.
Any other questions from the audience? Khalid.
I have a question to Raul. Now, every now and then we get some publications that would, some maybe right or false numbers, that Roux-en-Y gastric bypass increases the risk for colon cancer. And whenever that happens, it disturbs the practice. So is it about time for a document from the societies about the truth of the improvement of cancer incidence with bariatric surgery? You don't think so?
Yeah, I definitely agree with you. First of all, the studies are retrospective despite being large. You don't know for how long those patients that had a gastric bypass, a sleeve, a band, or an OAGP were obese. And we don't know when the cancer will ensue. That is also the reason what I said at the end. I think it's a time for us to update the guidelines, the new guidelines, because we are missing that. I don't think that we should wait for someone to be BMI of 30 and diabetic to get bariatric surgery if we know that being BMI of 30 without diabetes increases your likelihood of having cancer by 50% or 200% if you're a diabetic and obese. So when do you intervene? So I think all those studies lack the evidence because, again, large series, retrospective, they are not matched, and you don't know for how long they were obese. So it could be cancer would have happened no matter what, you know, with a facelift or with a gastric bypass. And that's the way I would interpret that.
So Raul, could you also comment about cancer in prevention in men and women?
Well, it is unfortunate that it's affecting more the menopausal woman, the hormonal-related one. And a lot has to do, and we're going to learn this afternoon from John Morton, with how our hormonal changes will affect telomere length. As we get older, the telomeres get shorter. As we get fatter, the telomeres get shorter. As you lose weight, the telomeres get longer. Unfortunately, we don't have yet the perfect science, but there seems to be that those endocrine changes in the postmenopausal woman plus obesity create a lot of telomere instability, the chromosome instability, and that's where cancer ensues. Even if it gets longer rapidly, there seems to be a likelihood of chromosome instability and you developing cancer. But getting shorter is definitely not good, and that's said by someone that is short. So,
Sure. Question to Andy. So you showed us in the literature that despite the evidence, which is not great, that sleeve is best for safety for the elderly and bypass is best for efficacy, hypertension, diabetes, reflux. So when someone comes to the office, how do you carry the discussion if the elderly 67-year-old has hypertension, diabetes, and has reflux? Which way do you sway him, towards efficacy or safety?
I think that is a really hard question to answer generally, because it really does, in these situations, come down to the individual that you're dealing with and what the risk-benefit ratio is for that person. Realistically, once you're over 65, many of the diseases of obesity are end organ. We've missed the boat. They should have had their surgery 20 years ago. And so what we're trying to do is improve quality of life and improve disease control. So I would go for the least risky operation that's going to give them the best chance of achieving what it is they're wanting to achieve.
Yes. Can you get the mic in the left? Okay.
Dr. Sandeep from New Delhi, India. This question is to Dr. Rosenthal. So for Asian population where the class 1 obesity cutoffs are lower, would you recommend surgery for a patient with BMI of 29 with no comorbidities, just on the future risk of cancer? Can we counsel a patient that you have a future increased risk of cancer, and hence we are justified in doing surgery? They have no diabetes, nothing, a BMI of 29 to 30.
29 to 30. I don't have the evidence to be so emphatic, but you know, if you look at what I just showed you, it sounds like we should start looking into that people should start looking at the incidence of cancer in patients with lower BMIs. You know, I cannot, you know, I think everyone here is probably a little bit overweight, or the majority. I don't know what an impact that has in our telomeres, in our genetics, in our chromosomes, that might make us prone to develop cancer. So I don't have those numbers to tell you yes. It might be, it might be. Remember that the BMI was not done by a physician, but an insurance guy. So we keep talking about BMI, we should stop talking about BMI.
I just add that it's not all cancers are equal, and esophageal cancer is the one cancer that there's probably no impact of metabolic bariatric surgery. And we've drilled into it quite a lot in our own series, and others have published this as well. And it's probably because it's a disease related to obesity, and as Raul said, possibly the cancer with this process, the pathway's already been set up before they have surgery. But the reality is most of the procedures we do are refluxogenic in one way or another, and bile does get delivered to the lower esophagus. Plus, unfortunately, the nature of esophageal cancer as it is for people that are centrally obese. So whilst you might be preventing some cancers, you're potentially putting them at risk of esophageal cancer. And so at the moment, until there's a stronger evidence base, I don't really think that that's a good indication for surgery.
May I comment on this? I think this is a very important point. So the cancer effect, protective effect of surgery is something that should be emphasized. And in counseling patients, it should be a factor in making their decisions. The question is a bit different when you say, can you use cancer as an indication to surgery, cancer prevention? I think that becomes a bit trickier. Besides the evidence, as Raul said, the problem is if you use surgery to prevent something, it all gets kind of muddy. Preventative surgery, even in cases of familiar genetic cancer like breast cancer to prevent, or thyroid cancer to prevent it from happening, is controversial. And in an environment where we have drugs that could be claiming to have some similar effect, I think we're not going to win that fight. You want to fight disease that are already established, where you can make an argument, I can treat it. So can you cure a cancer with bariatric surgery when it has happened? I don't know. Can you cure diabetes when diabetes has happened? I think we have the answer, yes. And I think if we insist on the disease we can treat, those are the indications that we can defend. Disease we can prevent, I think it should be counseling patients and making sure that we strengthen that message, but I'm not sure we can make it an indication for surgery.
Thank you. Any other questions from the floor? Right, I've got a question to Lillian, please. Lillian, you talked to us about ventral hernias at the time of bariatric surgery. What are your thoughts in the repair of, let's say, rather complex ventral hernias when doing concomitantly at the time of bariatric surgery? Should the operation be done by the same surgeon? Should we be asking the experience of another surgeon to scrub in with us at the same time to do the surgery?
I think, you have to look at the individual patient. If the patient is symptomatic from their hernia, whether it's complex or simple, then that may take precedence over their weight loss. But if you think that they can lose the weight and have a better operation, then I would recommend the two-step operation.
Thank you. All right. I would like to thank our speakers, the chair, the moderators, our audience. Thank you all very much for your time. Enjoy the rest of the event.